Hello, everyone. My name is Adhvaith Sridhar. I'm here to present our presentation on using math modeling in public health situations, specifically in the scenario of an H5N1 influenza outbreak to combat inequities in addition to the public health problem. And I'm here with my colleague Peter Shu, and we're excited to present to you guys today. So just to provide some context into what we're doing today, we are exploring a situation where the currently occurring avian flu or H5N1 influenza, which is a scientific name, outbreak has theoretically been spread to humans from birds, and we're going to be showing how we can use math modeling um, to serve as a framework for an equitable and effective public health response. And so really drilling into the impacts of math modeling in other fields such as public health. And we really want to emphasize that math modeling and data-driven processes can be used to solve existing disparities in the field of healthcare access. And so first, we'll give you a brief context into some of the disparities that currently exist in our home state of Minnesota. Next slide, please. So the first one is the geographic disparity. Minnesota has a very diverse geographic density where certain areas are very rural and have less healthcare infrastructure than do some of the urban areas. There is also a socioeconomic disparity, which is highlighted in the access to healthcare and health insurance, which can sometimes serve as a barrier to seeking care that is necessary um, for health. And then there's a cultural disparity, and this is kind of rooted in history where sometimes marginalized and under-resourced people tend to have greater instances of chronic medical conditions and a lack of access to healthcare help, which puts them at greater risk to a potential infection. And we say is almost random chance where people with high risk conditions are more susceptible to acquiring this H5N1 influenza and can lead to higher rates of comorbidities, mortalities, which is very unfortunate. But this fourth disparity is a little bit more random distribution over a geographic area than the other three. Next slide, please. And so here is what a potential public health response might look like. This kind of shows how each of the responses in the blue boxes address one of the four vulnerabilities or disparities that we went over on the previous slide. And all of this together constitutes what would be an effective public health response to an outbreak of the H5N1 influenza if it did spread to humans. And next slide, please. And all of these parts of the framework depend on gathering data in order to ensure that resources and help can be sent to the areas that need them most and in a timely and effective and efficient manner. And so this is where our mathematical model comes in, and Peter will go through that now.
So our goal of using mathematical modeling is to assist in H5N1 surveillance, diagnosis, and intervention. So basically, we developed a predictive model to estimate the number of H5N1 cases at any point in time, and also the geographic spread patterns of the cases. And we also have an ability to provide live updates to case estimations and geographic spread estimation as data is gathered in real time. And this data and model can be used to inform resource allocation, such as like vaccination distribution or like other resources that may be needed. And then for data gathering, avian cases and human cases will be collected and reported alongside the geographic location of the case and database. And the data is generated from self-reporting to the MDH website based on healthcare worker administered RT-PCR test results. and deployable pod guided test results, which we'll talk about later on. So our model is kind of based on what's called the SRI model. So essentially the SRI model is an epidemiological model that's used to describe the spread of infectious diseases. It stands for susceptible, infected, and recovered. And it is a compartmental model to model the spread of disease in the population by tracking the number of individuals in each of these 3 states. So in the SRI model, an individual will start in the susceptible state, meaning they're at risk of becoming infected. And then once they do become infected, they are moved on to the infected state, and which then they can move to the recovered state once they have recovered from the disease. So the SRI model is a simplified model that provides a rough estimation of the spread of the disease, and it can be used to estimate the number of infected individuals over time and the overall impact of the disease on the population. The model is widely used in public health, and it's also a helpful tool for like policymakers and public health officials to understand the potential spread of a disease, and it can be helped to make informed decisions and how to respond to like a public health threat. However, the model assumes that like the population is homogeneous, meaning that all individuals are equal in terms of their susceptibility to the disease and the rate that they become infected and the rate that they recover. The model assumes that recovered individuals are immune to the disease and that they cannot become infected again. It also assumes that no one is added to the susceptible susceptible population via like births or immigration. So since the mortality rate of the H5N1 virus is like relatively high, and our solution is to combat the virus via like distributing a vaccine, we thought it would be more appropriate to add a diseased and vaccinated state. And with the new states, our differential equations from the SIR model will also have to be changed. So the SIR, D, and V are all time-dependent functions, where S is the number of people susceptible, I is the number of people infected, R is the number of people recovered, D is the number of people deceased, and V is the number of people vaccinated. And similar to the SIR model, our model uses the following parameters, where N is population size, beta is dynamic infection rate, gamma is recovery rate, mu is mortality rate, and nu is vaccination rate. And to change from the SIR model, we basically added the dd over dt and dv over dt, and then we had to subtract that from ds over dt and di over dt to accommodate for these new states. And to simulate our SIR-DV differential equations, since our model, similar to the SIR model, it's still a compartmental model, and the differential equations shown earlier can also be thought as a flow from one state to another, which is shown in the top figure, where from the susceptible state, it can either flow, the population can either flow into the infected state or the vaccinated state. And from the infected state, one can either flow into the recovered state or the deceased state. And to essentially simulate this flow, we used PyComod, which is a Python package for building and running compartment models derived from systems of differential equations, which is exactly what we're doing here. And internally, this package implements a numerical differential equation solver to solve the equations in discrete time steps, and it generates like a time series output for the state of the system. And the code below shows the flows. And then we also introduce stochastic elements and Monte Carlo simulations into our model as well. So first, we specify the infection rate and mortality rate with like two parameters, a mean value and a standard deviation. And then we create the transmission rate beta and the mortality rate mu, which was shown earlier in the differential equations, as like a pi co-mod sample defined by a lambda function that calls the numpy's normal RNG, passing the mean and the standard deviation as parameters. So this essentially will resample our beta and mu values from a normal distribution at the start of each model run. And then next, our flow, also known as FSI, which is the flow from susceptible to infection rate to infection, has been updated such that, like, rather than being a deterministic rate, each susceptible person has a probability of remaining susceptible or being infected based on the number of people infected in that population and the transmission rate. So therefore, we use the binomial RNG to generate a discrete and random number of new infections that will move people from the susceptible population to the infectious population. And then similarly, the flow from infected to recovered has also been updated such that each infected person has a probability of recovering in each time step, again, using the binomial and RNG to generate a discrete and random number of people. And this in turn will also add randomness to the discrete state, as that depends on the recovery state as well. So with our newly introduced variability based on the uncertainty in transmission rate and the mortality rate and the randomness of events, we can create a Monte Carlo simulation. We ran the simulation, we ran the model 100 times, and we plot the middle 50% of the runs, also known as like the interquartile range or IQR. That's shown at the right. And then since our model essentially assumes that the population is homogeneous, we obviously can't apply this to the entire state of Minnesota. But historically, the counties that have been most impacted by like avian flus and other influences similar to this, those counties have mostly been homogeneous themselves. So what we can do is we can take our model and just apply it to each county individually, and then we can tune our parameters based on the data that we are given.
All right. Thank you, Peter, for the explanation of the model. I'll now go a little bit into the specific details about how the data is collected from an on-the-ground public health context. Next slide, please. So in the first place, the screening and diagnosis of human cases is important to collect because this data will help in the sensitivity analysis and refinement process of the model. From a health context, the influenza cases can be screened with a type of testing called RT-PCR testing, where the results can have a very rapid turnaround rate. And so the instant results, instant availability of the test results enables a relevance to the data that is collected. And so by the time the data is collected and incorporated into the model, it will not become irrelevant. It still is up-to-date data that can really be helped to increase the sensitivity of our model. And so this would be the way that cases are tested specifically. Next slide, please. It's also important to monitor and test and detect farm birds, so poultry that could be the cause for avian to human spread. And so a technique called reservoir monitoring is used, which is just a way for health department units to send out staff to monitor the poultry on different farms and establishments and isolate and quarantine these birds, as well as collect data on any unusual illnesses, deaths, as well as any indicators of the avian flu. And this data can be used to predict where a spread to humans might occur, as well as potential origins of outbreaks. Next slide, please. And I think one of the most interesting ways to view the model in the context of a response is to see how the data can be used to really put together an effective response. Next slide, please. And the first way to do that is using the data to allocate non-pharmaceutical intervention resources. This really boils down to personal, community, and environmental interventions, such as sending in supplies like masks, hand sanitizers, and test kits, and for the places where we believe we have the strongest chance of preventing an outbreak. And another important feature to think about in the state of Minnesota that we're modeling for is that a lot of the people who are susceptible come from a migrant population who are here to help on farms and similar establishments. And these migrant workers often have households, very larger households, where the farm owners and a lot of families will come together to live together. And this might not be the best from a public health standpoint during an outbreak. And so it's important that we know where exactly these kinds of larger um, family joined households will be affected in order to send in supplies such as temporary housing or alternative housing for the affected peoples in a way that is effectively used so none of it is wasted, and in a way that is timely so that the response can be effective. And finally, there are some environmental interventions where workflow changes um, to crucial community workers takes place, and that requires additional resources that would need to be allocated according to the predictive model as best as possible. Next slide, please. Another important public health response is a vaccine rollout, and so an interesting feature of a vaccine rollout would be the phase system, which provides vaccines in order of who is most susceptible or who is most exposed to an influenza. And we have 4 phases, 3 in kind of a phase 1, but sub-phase, and then a second phase, which is the general public. And so the vaccine rollout would also be dependent on the model, because we want within each phase, phase 1, and within each tier, for instance, phase 1, tier 1, we want the people in the most susceptible areas geographically to be given the vaccine. And so while a general public health response might have these phases and the tiers, incorporation of the model can provide further differentiation inside each tier to increase the sensitivity and effectiveness of a response. And so so that is how the model would be used in this kind of situation. Next slide, please. Another phenomenon almost that occurs in situations like this is surge management. And so during outbreaks, different healthcare systems can become overwhelmed if they are not. The areas most affected by the avian flu outbreak are rural areas where healthcare infrastructure is less resourced compared to perhaps the greater Twin Cities area, Minneapolis, St. Paul area, where there are more hospitals to serve a denser population, where the University of Minnesota is located, and where there's a greater healthcare infrastructure available. So the model also enables surge management responses to be sent into locations where we can predict will be overwhelmed. So if we know exactly how many hospital beds are in each county and how many staff members they have and what their maximum capacity is, and then the information from the model on where we think the cases will come up, we can put that together to effectively respond to a surge. Next slide, please. And finally, here we have a little bit of an innovative solution to an outbreak like this, which would be a deployable pod. And this pod reflects the ideas of telemedicine, where people can receive health remotely from their um, primary healthcare provider. And so we've kind of worked on the preliminary design of a pod that could provide information and remote connectivity to their healthcare provider, as well as a secondary pod with built-in RT-PCR test analysis capabilities. And so these deployable pods, they would be manufactured in limited number based on funding and resource availability. And so these pods would be deployed in areas where the model indicates an immediate almost test result data collecting would be beneficial. And so that's where a solution like this might also be supplemented by data from the math model. And so that sums up our public health context. But before we wrap up our presentation, we'd just like to take a couple minutes to talk about modeling and education and the importance of math modeling just broadly outside of maybe a public health context. Next slide, please. Next slide as well. So math modeling is so useful in a multitude of situations. I know Peter and I have both worked on math models in situations ranging from predicting animal behavior to helping people find the best summer job. And so a lot of these are not only fun, but also useful ways to put math into real life and help solve problems that people have. So math modeling is it's versatile and not only can be used, as you might be seeing throughout this conference, a variety of situations. And next slide, please. And finally, both of us we're fresh out of high school, and during our high school years, we did a lot of math modeling competitions, which I think is the source or root cause for why we're able to have an interest in math modeling and kind of apply those into different situations. And so we think it's important to stress the importance of math modeling in education, that it's never too late or too early to start. And it's so useful for so many situations that it's just an excellent skill to develop over time. And so that concludes our presentation. Thank you so much for joining us today, and we appreciate your time and interest.
Yeah, thank you so much.
Abdi, you have a question.
Yeah, very quickly, thank you for the talk. It was really quite interesting and illuminating. Could you go back to slide 8 just briefly so I can see how you change your equation? Okay, if you can hold on for 1 second. I don't have any questions. I just wanted to see how the equations came about.
Well, I actually have a question or a couple comments. I thought this was really nice. I really liked how much time and effort you spent to giving thoughts about ways to intervene. I really like that about the routes of transmission, trying to think about how to intervene. I guess, well, I have a couple questions. I'm just wondering, like the vaccination, the number of people vaccinated, did you do any thought process about whether, like what would happen if it was a low number of people vaccinated versus a medium number versus a high number? Like, or did you just have a number or some probability of the number of people being vaccinated? Like I'm trying to just figure out how you decided that.
Yeah. I believe the vaccination pattern was actually modeled after the COVID-19 pandemic data that we were able to obtain. I'll let Peter kind of expand on that as well if you'd like to.
Yeah, so like essentially we assumed that the number of people originally vaccinated was 0, and then we had to. This isn't too like historically accurate, but we just set a constant rate of vaccination essentially.
Yeah. I guess I'm also kind of curious. I don't know how hard it would be to extend this model to include my idea here, but one of my ideas is what happens if the vaccination wanes, which is what happened, I know, with COVID-19, that you would get vaccinated and then maybe 3 months later you're no longer vaccinated, essentially. So I'm wondering if you had given any thought to having the model. I don't know how H5N1 works. Maybe the vaccination for H5N1 is like the vaccination for chickenpox. Maybe once you get vaccinated, you're really vaccinated. Do you know? I don't know much about it.
Yeah, so like
Yes.
so like for this case, I think if we go to our next slide, we have like the compartments and the flows. Like
Mhm.
if like theoretically like the vaccination would wear off, we could introduce like another parameter, and then we would draw another arrow from the vaccination to the infected as well. And then we would it would look something like we would just for the model for the differential equation, we would, on the di over dt, we would just add like another parameter multiplied by the number of people vaccinated.
Yeah, that would be interesting to see. I have one more question, but I don't want to be the only one asking questions. So I'll pause and wait and see if somebody else wants to ask something. Okay, well, maybe I'll go again. I like the idea of the deployable pods. Are those meant to be like something somebody would hold in their hand, or this is like more like a trailer that would be pulled by a truck, or is this more of like a concept?
Yeah,
Just
great
a
question.
concept idea.
Yeah, it's still a conceptual idea. We've only designed and kind of theorized about the cost of production theoretically, but it would actually be between the two sizes that you said. So it'd be something that would maybe the size of something that could fit on a desk, perhaps. So not something you could hold in your hands, but not as large as a trailer, and so it would be. The whole point is to kind of make it deployable and movable to where kind of the uses of the pod are most needed. And so it's just something we thought about to add.
Something that could probably be shipped through FedEx or something, like through a courier.
Yeah, precisely.
Okay.
Yeah.
And I guess, we're almost out of time. One other thing I would say, in your slide where you had the different phases of where you would, this one, the vaccine rollout. I know you had assisted living residents on there. I see that. And I was just thinking more generally about people that are in institutions, like people that are in group homes or people that are in prison. So I'm wondering if you continue to work on this, if you include them somewhere in your phased rollout, because they're also pretty vulnerable because they don't have any control over their situations. So that was just my only thought process about that. Maybe it's in the list and I just didn't see where you were including that. But
no, that's an excellent comment. Definitely something to incorporate going forward.
Yeah, this was great talk. Any other questions for our speakers you guys are from University of Minnesota?
Yep.
All right, well, we'll give you a round of applause. Thank you, everybody.